It is 7 o'clock, so we are going to get started. My name is Dr. Yolanda Lindsay, and I'm the co-chair for the Empower Her series, a year-long series of conversation on topics of keen interest to Black women that we often don't talk about. Tonight, in honor of Infertility Awareness Week, we are hosting the 5th and final conversation on the topic of fertility and infertility in Black women. Infertility affects 1 in 6 couples and at least 12% of all women up to age 44. Data suggests that Black women are twice as likely to experience infertility as white women, yet they seek treatment about half the rate. So this is definitely a topic that we need to increase conversation about. We are grateful to all of our fantastic speakers that have donated their time to educate and discuss this important topic tonight. We would also like to thank our sponsors, the Greater Springfield, Massachusetts chapter of the Links Incorporated, the Magnolia, Georgia chapter of the Links Incorporated, Boston IVF, and Progenesis Incorporated. Towards the end of the webinar, there will be a link in the chat for you to take a brief survey about your experience on this webinar. We greatly value your feedback, and it also helps inform what programs you would like to see in the future. Before we get started, we would like to begin our evening by greetings from Ms. Yvette Frisbee, President of the Greater Springfield, Massachusetts chapter of the Links Incorporated, followed by Ms. Jacatherine Ross, Health and Human Services Facet Chair of the Magnolia, Georgia chapter of the Links. President Yvette.
Thank you, Dr. Lindsay. Good evening. I bring you greetings on behalf of the Greater Springfield, Massachusetts chapter of the Links Incorporated. Our Empower Her webinar series has been devoted to the overall well-being of Black women. Tonight's webinar would not have been possible without the dedication and tireless work of Dr. Yolanda Lindsay and members of our Health and Human Services facet, chaired by Terry Burke. I would also like to thank this evening's sponsors, and it's always great to partner with another Links chapter. So I acknowledge and thank the Magnolia, Georgia chapter of the Links Incorporated. Thank you to our keynote speakers who will share their knowledge and expertise on infertility and fertility in Black women. You will meet our panelists in the breakout rooms, and I'd like to thank them for their willingness to share their journey with us. And to all of you, thank you for sharing time and space with us this evening. I hope you find this webinar informative and helpful for yourself and someone you know. Good evening.
Good evening. I am honored to bring greetings to you on behalf of the magnificent Magnolia, Georgia chapter of the Links Incorporated. Our president, Dr. Dion Griffin, our program chair.
Did I mess it up?
When you put inside, we cannot take it out.
Oh, okay.
If you all could please mute your microphones, that would be wonderful. Sorry about that, Ms. Ross.
No problem. Through a collaborative effort with the Springfield, Massachusetts chapter, the Magnolia chapter is providing education and resources to address the injustice that permeates the Black community in the area of infertility. Community education about health risks, maintenance of good health, and health disparities in communities of color is crucial to the Links. And many Black women facing infertility say they face an uphill battle in getting care. Challenges include not having insurance that covers the cost of infertility services, a lack of Black sperm and egg donors, prejudice from physicians, and feelings of shame and isolation. So tonight, we have the opportunity to dispel many of these myths and demystify the topic. We have some of the best experts with us, so take advantage of this opportunity to ask your questions, listen, learn, and gain the knowledge you need to make informed decisions. Thank you so much for being with us tonight, and I look forward to learning with you.
Thank you so much, Ms. Frisbee and Ms. Ross. So we are about to now introduce our keynote speakers. I will introduce all of them, and then we will have 4 keynote speakers, and then we will I will come back and introduce our breakout room leaders. So our first speaker is Dr. Tia Jackson Beck. Dr. Tia Jackson-Bay is a board-certified reproductive endocrinologist and infertility specialist who cares for patients at RMA of New York in Brooklyn, New York. Dr. Jackson-Bay works with various organizations and medical societies to enhance fertility options for underrepresented minorities, reduce health disparities, and improve access to care. She is on the boards of Fertility for Colored Girls and the Broken Brown Eggs and serves on the Diversity, Equity, and Inclusion Task Force for the American Society for Reproductive Medicine. Dr. Kim Thornton is a director of reproductive endocrinology and infertility at the Beth Israel Deaconess Medical Center and a practicing reproductive endocrinologist at Boston IVF. Dr. Thornton is a member of the ASRM Diversity, Equity, and Inclusion Committee, where she is leading the subcommittee charged with enhancing opportunities to increase and support diversity and equity and the inclusion of underrepresented minorities in the profession and leadership of reproductive medicine. Dr. Oluyemisi Famuyiwa is the founder of Montgomery Fertility, an associate clinical professor of obstetrics and gynecology at the George Washington University School of Medicine. Dr. Famuyiwa is a staunch advocate for fertility preservation, especially in cancer patients. Finally, Reverend Dr. Stacey L. She is the founder of the nonprofit Fertility for Colored Girls and is the author of the book, Hold On to Hope, Stories of Black Women's Fertility, Faith, and Fight to Become Mothers. At this time, I will turn it over to Dr. Tia Jackson-Bay to take it away. Thank you.
Awesome. Well, thank you so much for the introductions, and just know that we are all super excited to be here. I'm going to share my screen so we can start with our initial presentation. I wanted to talk primarily about, what are some of the challenges that we see in terms of infertility in Black women. So one moment while I just pull up into presentation here. And so I'm hoping everyone can see my screen. Again, I'm Dr. Tia Jackson-Bay. I'm a reproductive endocrinologist and infertility specialist based in New York City. I'm affiliated with Reproductive Medicine Associates of New York, as well as the Icahn School of Medicine at Mount Sinai. So there are a few basic tenets that I want everyone to kind of really understand in order to absorb everything that we're going to share today. One is that infertility is a disease. This is not a social problem. It's not a rich person's problem or a poor person's problem. It is literally a malfunction of the reproductive organs. And it's something that I think I try to put into context for people, really to take the blame away from themselves, the guilt, the pressure. Sometimes we may find that there's a one issue that's happening that's contributing to the infertility. And just a reminder to try to mute yourselves as you come into the presentation. Just take a moment and see if you're muted and do so. But infertility is absolutely not a social or a religious or any other kind of punishment. Infertility does not discriminate. And so I think something that maybe comes as a surprise to many Black women is that we too are affected with infertility. Despite our upbringing and stories we've been told about ourselves and stories that we even tell each other, there is no reason why we also could not be affected by this. And it's absolutely very real. And infertility is not a dead end. A lot of times it can feel like a very devastating diagnosis, but I think the most important thing to remember is that there are so many options available in terms of surgical, medical, treatment options. And so it doesn't have to feel like the end of the road. One thing that I think many of us may be aware of is this disparity in terms of Black women having an increased risk of death either during or after childbirth. It's called maternal mortality. And I think it's been getting a lot of press and attention in the past few years, which I'm not happy for the statistic, but I'm happy for the momentum that it's gaining and hoping that it will actually affect change. But one thing I think is less appreciated is the interplay between maternal mortality, infant mortality, reproductive and sexual health disparities, infertility disparities, and then pregnancy loss, including miscarriage and stillbirth. The factors that affect one very frequently affect other parts of this dynamic. And that's something that we, again, have to make sure to bring to the forefront when we're using our voices to speak up against maternal mortality and infant mortality, and realize that it's part of a continuum. And so unequal health in the field of reproductive medicine looks like Black women presenting for care half as likely as white women. They usually have a longer duration of infertility at the time in which they enter care. In many cases, a lower utilization of effective treatments, higher rates of treatment discontinuation, and in many cases, poor outcomes even after treatment is initiated. And this is just unacceptable, and we want to work to change that. But, often I think of these disparities as really the tip of the iceberg in terms of there has to be an undercurrent. There has to be something else happening beneath the surface that explains this. There's so much more than what meets the eye. And so, one area that I really have focused on is this concept of the Black fertility myth. And a lot of people want to know, what is it and what exactly does that mean? But in my own upbringing, in my interaction with the community, with the public, I found this very common theme that people felt that Black women were immune to infertility, and actually that they had hyper or super fertile capabilities. And unfortunately, that actually works against us when it's time to address some of the issues that we're going through and even enter into treatment. So if I had $1 for every time I was told Black women don't have infertility, or in the converse, that Black women are super or hyper fertile, then I think I would be able to pay off my student loans. And so, I show this picture of my family very frequently. This is the large family, just a portion of it that I grew up in. And again, understanding our origins, understanding where we come from in this country, I think is a very important part of understanding what are some of the cultural myths that make fertility so stigmatizing. And, a lot of us are very much aware of the legacy of slavery in this area, but, thinking of not just large families as a natural occurrence, but also as a mode of survival, as a mode of force and brutality, that was something that we did not have control over. And so to think that this was just a natural state of being was not exactly the full picture. This, women having large families, having multiple children, men, having multiple children as well, was a product of the design of our being enslaved in this country. And so there's a huge impact at the individual level, if we kind of continue on with this idea that Black women are super fertile and could not possibly experience infertility, then, we allow our family history of even having large families or stories of later conception can actually be misleading in terms of what is possible, and may allow women to seek care at a much later age than they probably should have. I personally think that this contributes to significant grief from when they do encounter an infertility diagnosis, because it just comes out of the blue instead of something that you were prepared for or you could have, heard about before in your community. A lack of social support in terms of people around you who are affected, knowing what resources and options are available. It can be very isolating and stigmatizing. And then also a lack of what we call reproductive awareness, which is just, what is happening, what's going on in your body, and when is the appropriate time to seek treatment, as well as we understand the very undercurrent of mistrust of the medical system. There's also an impact of this stereotype at the provider level. If providers also think that Black women don't have fertility issues, then they may not refer you, even though it's indicated for fertility care, or they may refer you much later than necessary. In some cases, we focus so much on contraception that we don't think about the other side of it. What happens when you are ready to have a family? Or what happens if you've had cancer treatment or entering cancer treatment, or even treatment for uterine fibroids without discussing family building options first? So we know, and we'll discuss today, that natural fertility declines with age, and this is due to many reasons over time: decreased ovarian reserve, semen parameters, and unfortunately that does contribute to a decreased pregnancy rate and decreased live birth rate. At the same time, we see an increase in miscarriage and an increase in aneuploidy, which is a chromosomal abnormality of pregnancies. Black women in particular have some things that can increase their chance of infertility, such as higher rates of sexually transmitted infections, and higher rates of permanent sterilization and surgical management of ectopic or tubal pregnancies, which can hinder your fertility in the future. There can also be a significant uterine factor, is what we call, largely due to the increased prevalence of uterine fibroids in Black women. And we'll talk a bit about that during the course of this discussion. Ovarian factor is also important. There's kind of two extremes here, when the ovaries have lots of eggs, but it's not really utilizing them well, as in what we see with polycystic ovarian syndrome, or when the egg count is significantly low. So again, I don't want you to forget, infertility is a disease, okay? This is not something that people have brought onto themselves or something that anyone would wish to have, and it deserves to be treated like a disease. Infertility does not discriminate, and infertility is not a dead end. I just want to thank you for allowing me to present today. This is just information about my practice and how to find me on social media, as well as a podcast that I started this year.
Thank you so much. Dr. Thornton.
Great, let me just share my slides and we'll go ahead and get started. Hold on a second. Give me 1 minute. I did this and then I did it in the wrong order. You should be able to see the slides now.
Yes.
So it's a pleasure to be able to speak with you today. I'm going to give you a brief overview of the evaluation and treatment, really just highlighting the most common treatments that are offered for fertility patients. So in terms of the definition of infertility, most of us consider couples infertile or an individual infertile if they've been trying to conceive for a year without achieving a pregnancy, understanding that most pregnancies occur within 6 months. We often talk about impaired fecundity, mainly because in addition to patients who cannot conceive, we oftentimes will see patients who have recurrent miscarriage and other problems that prevent them from carrying a pregnancy to term, even though they've had a successful pregnancy initially. There are a number of different causes that Dr. Bay highlighted, but you will see women who, or we see women who have tubal factor infertility where the fallopian tubes are non-functional, women whose ovulatory function is dysfunctional, if you will. Many women don't ovulate regularly. And there are some individuals that actually have premature loss of ovarian function at a younger age. Endometriosis is a common cause of infertility. It often is associated with chronic pelvic pain and can cause inflammation within the pelvis. And then we can't forget the fact that for couples who are trying to conceive, oftentimes many of our couples have their husbands have a male factor. And then in many instances, you have couples that have both female factors and male factors in combination. When we talk about evaluating patients, in addition to those patients trying to conceive for over a year, we are a little bit more aggressive for women who are older. So if you're over the age of 35 with no conception for 6 months, an evaluation is indicated. And then there are a number of instances where one might suspect that they would have problems because of pre-existing conditions. So for instance, a woman who doesn't ovulate and therefore doesn't release an egg is not going to be able to conceive. A woman who has tubal blockage, either again, an infection, she's had abnormal, or she's had pelvic surgery and now has an abnormal ultrasound, or has had fibroids removed, for instance, might have adhesions that would impair fertility. And then for the men, erectile dysfunction, prior trauma or surgery might be indications to investigate someone sooner than that 1 year time frame. Age is a fairly significant predictor of a woman's ability to conceive. And I think that this slide depicts very well the impact of age on overall likelihood of achieving a pregnancy in patients using their own eggs, non-donor eggs. And you can see that whether it's pregnancy, live birth, or singleton live birth, as women age, the likelihood of pregnancy significantly decreases. Fertility testing addresses all components of the female reproductive tract. So for instance, when we're looking at tubal factor infertility, one of the tests that will be performed is a hysterosalpingogram. That is a study that places dye, radio opaque dye, into the uterine cavity through the cervix. It outlines the cavity and fallopian tubes. So you can get a nice picture of whether the fallopian tubes are damaged or whether they're completely normal in appearance. That's done early in the cycle before ovulation. Ovarian function testing is typically done on day 3 of the cycle. It includes FSH levels, which is a hormone produced by the pituitary, estradiol levels, which is an ovarian hormone, and then a hormone called anti-Müllerian hormone. And then the other common test that's performed in the male partner is the semen analysis. I'm going to skip over a couple of these. Anti-Müllerian hormone is one of the markers that we use quite commonly. And the reason that we do the AMH is it provides a fairly stable marker, an indicator of ovarian function. And again, it's one of these hormones that will decline as women get older. So it gives us a good sense of how we can predict success. And in this particular graph, without going into too much detail, we've been able to demonstrate is that we can predict, in fact, the likelihood of retrieving a certain number of eggs with IVF based on anti-Müllerian hormone levels. So for individuals who have normal AMH levels, they may have an 80% chance of conceiving, or I'm sorry, of retrieving 8 eggs. Whereas if their anti-Müllerian hormone is very low, that chance of retrieving 6 eggs or more is really reduced. I've already described the HSG. This is just what the X-ray would look like, showing the uterus, the internal cavity of the uterus, and fallopian tubes, with dye going through the tube and then spilling out. And then finally, semen analysis parameters, normal parameters, just so that you guys are aware, indicate a semen volume somewhere between 1.5 ml and 5 mils, concentration of 15 million motile sperm per milliliter, and the motility should be 40%. Sperm morphology should be 4% or greater. And in most instances, if there are abnormalities in the semen analysis, we will repeat the semen analysis and then have husbands or partners oftentimes see a urologist. So in terms of treatments, what treatments are oftentimes recommended? Fairly conservative treatment includes ovulation induction and intrauterine inseminations, whereas more aggressive treatment would include IVF or even some of the third-party reproduction techniques such as egg donation or gestational surrogacy. Ovulation induction and NIAW is used in general for women or couples with unexplained infertility. The medications that we use are either Clomid, which is an estrogen receptor agonist. It blocks the estrogen receptor, makes your body think there's no estrogen around. And so the pituitary starts to respond, kick out FSH, and stimulate the ovary. So it's an indirect stimulus of the ovary. Letrozole is an aromatase inhibitor. It blocks the conversion of androgens to estrogens, and again, causes FSH levels to rise. With this treatment, the chance of pregnancy on a per cycle basis is about 10%, and the chance of twins is increased slightly, somewhere between 5 to 10%. Most studies seem to indicate that 3 cycles of treatment, within 3 cycles of treatment, most women who are going to conceive on that treatment will conceive, and after that, there's a plateau. So, you know, in most practices now, if they're offering intrauterine inseminations, they'll start off with 2 to 3 cycles and then move on to something more aggressive. Using gonadotropins for ovulation induction can be done, but it's a much more aggressive approach associated with a very high risk of twins and triplets, so not typically recommended. And then the process of intrauterine insemination involves placing a catheter through the cervix into the uterus to deliver a higher concentration of sperm into the fallopian tubes, which is where fertilization typically occurs. IVF, the indications for IVF are, other than unexplained infertility and failure to conceive with more conservative treatment, include tubal factor and male factor. The success rate of IVF depends on patients' age and the quality of embryos that they produce. The goal of the medications is to stimulate the ovaries so that you get multiple ovarian follicles that develop. And we then can go in and surgically harvest those eggs by putting an ultrasound transvaginally, introducing a needle through the back of the vaginal wall into the ovary so you can aspirate the eggs. These eggs are delivered to the lab where they're either inseminated with sperm in a standard fashion or with a procedure called ICSI, where sperm is injected into the egg and fertilization can occur. Finally, embryos are developed, and if everything goes well, you'll have embryos develop to the 4-cell stage, 8-cell stage, and then if they're 5 days in, typically 5 days after the retrieval, some of the embryos should develop into what we consider to be a blastocyst, at which point we would transfer that embryo back into the uterus. And that just depicts an embryo transfer. Add-on treatments include the ability to test embryos genetically for either numerical chromosomal abnormalities or single gene disorders. The last thing that I want to mention is egg donation. If I mentioned at the beginning that with maternal aging, the likelihood of pregnancy decreases while the likelihood of utilization of egg donation increases as a consequence. Egg donation may be indicated for women with early ovarian failure, advanced maternal age, genetic factors, and we have options for both traditional egg donation where you have a one-on-one donor recipient couple match, and probably more commonly now people are using frozen donor egg banks, and where donors have already cycled, the eggs are frozen and they're available for purchase. Gestational carrier is a situation where in instances where a woman either has a problem with the uterus, either an absent uterus or has had extensive uterine surgery, or has a medical condition that precludes her from carrying a pregnancy, or in for our same-sex male couples, we have someone who can carry the pregnancy to term. And then sperm donation is utilized for couples or single women, lesbian couples, and then individuals where there's a significant male factor and or genetic factor. The percentage of cycles using donor eggs has increased dramatically. And this was in 2010, where you can see that for women over the age of 40, that the utilization of egg donation has really increased. And the advantage of that is that whereas the success rates decrease with age, if you're using an egg donor, you can maintain reasonably high success rates. So I think I'll stop there. We can discuss further questions at our Q&A session at the end. Thank you.
Thank you so much. Dr. Famuyiwa.
Thank you. Good evening, everyone. It's my pleasure to be here. I want to thank all our sponsors, and also, can you hear me? Okay, good. So I'm going to go ahead and try to share my slide. Share. Okay, can you see that? Okay, great. All right, so let me get started. All right. So my name is Dr. Famuyiwa. I am the medical director of Montgomery Fertility Center, and I'm affiliated with George Washington Medical School. It's a pleasure to be here. Specifically tonight, I want to focus on increasing your awareness and your understanding of what we care about, the egg. It's all about the egg. It starts with the egg. So let's define what we want to accomplish after my talk. So I'm going to take a different angle. I think my colleagues have done an excellent job of the treatment and why we're here tonight. What I want you to take away from this talk, when at the end of the day, understand where your eggs come from. Understand the 3 possible things that could happen to the egg. And then understand what we refer to as that long pause in the egg development. And it is during that incredible long pause that the egg is vulnerable to damage. And that's why the egg gets older as you get older. That will give you an understanding of why we talk about the need for egg freezing. Now, the first thing I want to bring to your awareness is, I don't know if you're aware, but the human egg is actually the very largest cell in the human body. It's about the diameter of your hair strand compared to the sperm. It's about 100 times the size of the sperm. The human egg originates from some precursor cells in the hindgut area of a growing fetus, right? It starts about 2 weeks post fertilization, and then it migrates to an area of where the new ovary will be located. Now, another thing you should be aware is this initial cells that are the precursor cells for the egg, they actually contain the full complement of DNA from mommy and daddy. And before the egg can be used, these cells are rapidly multiplied. They go from about 50 cells to about 1,000 by 4 weeks. And guess what? They get up to 6 million of them by 5 months of pregnancy. That is a very, very rapid multiplication of cells. So what happens is when you have such a rapid growth, you're going to get a lot of mishaps, mistakes while this is happening. So maybe it doesn't pinch up very well. And the body's way of dealing with those accidents is to just clean them up. You have programmed cell death. And that occurs such that by the time a child is born, you're down to about 2 million of these cells. You've left around 4 million cells. Now, from then on, from birth till you die, you will continue to lose these eggs. They continue to be cleaned up and die. By the time you hit menarche, at around age 12, 15, whatever age, you're down from 2 million to about 200 to 500,000 cells of eggs, and about 1,000 by menopause. Now, why do we care about this? Well, the precursor cells have the full complement of DNA from mommy and daddy. That is 23 pairs of chromosomes lined together. In order for you to create an egg that can be fertilized, you have to separate the pairs so that you create half the genomic complement that can now fertilize with half the genomic complement in the sperm to create a new individual. Well, here's what's really interesting about nature. So we're going to pull these cells apart. We don't just pull them apart and just form two separate cells and then on downwards. Nature has a way of making sure that no two individuals are the same. It's going to shuffle the deck of cards. Like, you know, if you play cards, you shuffle it before you hand it over. Well, these DNA, they're chopped up, swapped around like Lego blocks before they're ready to pull apart. If you think of how many eggs combination you can get over 8 million combination. You're not going to be like your sister. So what happens is the process of pulling them apart. Now I've shown it in this diagram. It started halfway through. This process starts before you are born. At birth, it's actually frozen, right? It doesn't complete. So we can learn about cryogenics. We don't need to go to space. We can learn about cryogenics from the egg, because this process is stopped, halted, and it doesn't resume until you ovulate at puberty. And if you don't ovulate it, it could stay there till you're menopausal. Now, the problem is, I want you to pretend you remember when we were kids and you were playing musical chairs, and then the music stops and you freeze, right? And you've got to sit down. Except instead of sitting down, you sit halfway down and then you're frozen. Well, if I freeze you for 15 years or 55 years, sooner or later, your muscles and your bones are going to start creaking and snapping and doing whatever, because you can't stay like that forever. So what happens is, if you will, the mechanism that pulls the DNA apart, these strands over here, they start to be susceptible to damage. They can break up. The lynch at the end here that kind of reels them in, that can also break down. The things that can break this down, what you do with what your body is exposed to. So we talk about lifestyle, toxins, free radicals can break down these tubules. So let me progress this so you can see what happens when you're successful. And now remember, this process doesn't complete until after birth, but it gives you an idea how delicate this genetic material is and must be separated and is susceptible to damage. What can damage the DNA? Free radicals, right? Waste product of just being alive. Radiation, chemotherapeutic agents, smoking, what you expose your bodies to. And by the by, medical marijuana can also enhance this damage. Just FYI. So now that we know what can damage the cells, let's go back to, we talked about the 3 possible things that can happen to the egg. They can stay dormant. They don't have to do anything. They can just stay in that pool of reserved cells. They can move to a temporary pool where they're half activated, from which they'll be called to active duty when they become activated by the brain, or they can die. And that death, like I showed you, goes on. You lose about 1,000 eggs every single month. Death is a constant. While they're in the dormant state, they die. When they're being activated, they die. When they're activated, they die. They constantly will die. When they are called into active duty, right, they're called in waves of cells. They don't just open the floodgate and every egg flows out. And if, by the way, if you do that, if you call off all of them to active duty, as chemotherapy can do, you open that floodgate, you will empty out the ovary of healthy cells, and then you go into menopause because they're done. So some chemotherapeutic agents don't necessarily kill the DNA, some do, but some of them just activate all of them at once, and then boom, you're done. So the way you protect those patients is prevent that premature activation. So what happens when you're activated, right? The process of calling them to active duty, right? That can take over 200 to 300 days. It doesn't happen snap, boom, they're ready to be divided. They have to grow supporting cells. They have to develop and grow big. Remember, they're the biggest cells. The initial stage is called the gonadotropin independent stage. It takes about 150 days. They don't need the brain's help. They get up to about 8 to 10 millimeters, at which time they can now respond to signals from the brain. And that takes another 75 days or so prior to ovulation. So if we look at it from this picture, so you have the fetal egg in the baby, starts to grow, multiply, then is frozen from birth until puberty or menopause or the entire reproductive lifespan. During this frozen state, right, this cryogenic state, they are susceptible to damage and they can die. They get to a certain size, they can now be picked up by FSH that Dr. Thornton had explained to you, and they can now be triggered to ovulate by LH. Incidentally, they don't complete the entire division until the sperm hits the outer layer of the egg is when you complete that process. Why is that? Well, why activate them when there's no sperm around, right? So this other slide shows the entire process from, young primordial pool stage, being activated over here, now being ovulated, and then they're done. Now, look at this slide. What I want to impress upon you, they die every step of the way. They die while they're waiting to be activated. They die while they're being activated. They die before if they don't get to be the choice to ovulate. What happens is when the brain gets ready to stimulate you to ovulate, the brain is going to select what I call a basket of the partially activated eggs, right? This one's sort of in the middle. Let me put my pointer here so you can see. It's not going to go after this ones. It's going to select some of these partially activated ones. And then from that basket, it's going to choose one to ovulate. And guess what? They're not dead yet, but hey, the brain then, kind of tosses that basket. So each month that you ovulate, you're also tossing that basket. Now, this leads me to the topic of what then do we do when we say we're freezing our eggs? What we're doing is we're trying to we're trying to get some of these activated eggs before they are tossed out of the basket, before they hit this ovulation stage. So the stimulation that Dr. Thornton told you about is going to grab these cells over here, try to grow them together, and then we're going to try and collect that basket and save that basket. That's the process. So I'm not going to go into the details of treatment. I think she did an excellent job of doing that. You can go back to her slides and review it. So we talk about how many eggs do you need to freeze? I'm sure you've heard this conversation. I think the most important thing out of this slide is you have to have the conversation with your doctor. When people ask me how many eggs should I freeze, I ask them, well, how many children do you want, right? So you have to think about that. If you only want one child, you don't need to freeze that many. Maybe if you're less than 35, 10 to 15 mature eggs. If you're older, you're going to need more. Well, guess what? If you want more children, and this slide shows why we don't always freeze everybody's eggs, is the number one, we talked about they're dying every step of the way. They're susceptible to damage every step of the way. So in other words, they're getting older. So in order to have the likelihood of having a child, you would need more mature eggs as you get older. Well, I can tell you right now at 42, I doubt you're going to get 80 cells, really. So you really want to freeze your eggs when it's possible to get the number of eggs that you need at a younger age. And if you want more than one child, you might want to freeze more than once. So again, I hope that I have explained the complex nature of the egg. I hope you understand why the egg is susceptible to damage from the environment, from your lifestyle. And I hope you understand what it is we're doing when we're freezing the eggs, trying to save some of the eggs that have been called to active duty before they are dismissed. They never go back. Once you're called to active duty, that's it. There's no going back. You either mature, ovulate, or you die. Thank you so much. I'm very honored to be part of this presentation. I want to thank all our sponsors and especially Dr. Lindsay for letting me be here.
Thank you so much, Dr. Famuyiwa. That was wonderful. And Reverend Dr. Stacey Edwards-Dunn is our final keynote speaker.
Well, good evening, everyone. Thank you, Dr. Lindsay, and the links and all of the sponsors. And we put a whole lot of claps in the chat for all of our previous panel. I'm mad at Dr. Lindsay for putting me last at the end of all of these great speakers. And so I am going to keep mine short. One of the things Dr. Tia Jackson-Bay lifted up at the very beginning was that infertility is a medical condition. And so as women of faith, and particularly people of African descent and women of African descent, or I like to say women who have been kissed by nature's son, we are spiritual people. We are steeped in a very spiritual tradition and a culture. And so for many of us, regardless of what religious tradition we participate in, we have a relationship with God or a creator or a divine being, a higher being. And for us, that is very, very important. And so for many of us, it becomes a struggle when we think about treatment, when we receive the diagnosis. And particularly from a spiritual perspective, for many of us, we hear statements like, if God wants you to have a baby, then God's gonna make sure you have a baby, you're gonna have that baby. Or maybe God don't want you to have a baby since you're struggling with infertility. Or in some traditions, we even hear that it's a curse by God. Or what have you done? Or how have you sinned? All of these statements come up. And I think for many of us, we have really been, I'm sorry for my background noise. That's my children in the background, my gifts from God who are being children. But for many of us, religion, one, has really been very counterproductive. And we have also really been miseducated theologically about biblical texts and who God is and how we are to function in relationship with God. So one of the things I think that is very, very important for us to keep in mind is what Dr. Tia Jackson-Bay stated in the beginning, is that infertility is a medical condition. And just as if any other medical condition, God calls us, God has put in position amazing physicians who are able to support us on our journey, and also has utilized men and women who are also of God, who have been created by God to create treatments such as IVF, IUI, etc., so that we can build our families. Yes, if we look throughout the biblical text, we don't necessarily see anybody experiencing IVF, because we also have to remember that the biblical text was written like prior to the 16th century, and much of what we receive in the biblical text is that we don't even receive it until very late, and it has been orally translated. But what we do know is that the women who did struggle and the men who did struggle with infertility in the biblical text, they partnered with God in faith in order to achieve their goal of becoming parents. I love to talk about one particular story. We talk about Hannah, we talk about Sarah, we talk about Rachel, we talk about Elizabeth, many of them who were older and end up having children in God's perfect timing. But what we also we fail to talk about is we fail to talk about Mary. Mary, who was a teenage mother, who gave birth to Jesus. I love to talk about her because for me, Mary was a young woman who experienced the first divine intrauterine insemination. And that's what I believe. That is our first IUI in the biblical text, but from a divine perspective, because the Spirit of the Lord came upon her, the text says, and she became pregnant with child. And her husband ended up adopting Jesus. She was the adoptive father of Jesus. Why am I saying this? For each of us who are thinking about and desiring to be parents, there are multiple paths to parenthood. The paths are different, but they are not deficient. And for those of us who desire, God has assigned us to a particular path. We have to simply be open to the path that God is calling us to walk down. In addition to that, I think that it's very important for us to realize that faith, which many of us quote from Hebrew 11:1, says, faith is the substance of things hoped for, the evidence of things not seen. Faith is this. Faith is that you have to see it before you see it. And if you have faith and you see things before you see it, faith without works is dead, which means that God is going to do God's part, but we too have to be willing to do our part if we indeed want to become parents. And that may mean that we may have to see a doctor to get some support, whether that's medications, whether that's IVF, whether that's IUI. We may have to seek a therapist to even talk about the suggestions and the recommendations that the doctors may even make to us if we have to. For many of us who have to decide to use donor eggs or adopt embryos, to talk to those doctors to support us on our journey so that we can ultimately achieve that goal of becoming parents. Many will say that there will be some of us, of course, that will not become parents, and we will choose not to move forward on our journeys. But I am crazy enough to believe that if you want to become a parent, you can become a parent. You may not necessarily be able to give birth to a baby, but you can become a parent. And I think that is very imperative for us as women to decide what's most important. Do we want to have a baby, or do we want to be a parent? Do we want to care for a life, for the gift of life, a miracle that God and the ancestors has sent our way, and help them to live out their purpose in life? And so again, when we begin to think about the question, does IVF and IUI and all of these other things contradict waiting on God? Absolutely not. If you trust God, if you consult God and seek God in prayer, asking God to discern and order your steps, and you are in line with what God is telling you to do, absolutely, it does not contradict God. But ultimately, when we do what God calls us to do, we ultimately give God the glory. And that is the end of my presentation.
Wow, thank you so much, Reverend Stacey. Reverend Stacey was preaching, right? That we went to church. That was amazing. So we are running a few minutes late. So I am going to truncate the bios of all of our wonderful breakout room speakers so that we can get to our breakout rooms much sooner. So go put some claps in the chat for all of our speakers while I introduce our breakout room speakers. So for the first breakout room, treatment options for infertility, Dr. Shoshana Myers is going to be there, and she's going to be representing her IVF journey. Dr. Lauren Powell, also IVF journey. Dr. Barbara Henley, talking about her journey with the use of donor eggs, and Rachel Scarrett with the use of donor sperm. In the second breakout room, which is additional pathways to motherhood, we're going to have Eloise Drain, who has great experience as a surrogate, as well as a provider of donor eggs. We're going to have her lead that room, as well as Caroline Hilton, who's from the Magnolia chapter, is going to talk about her experience with surrogacy, and Aisha Francis Samuels, her experience with adoption, and Pia Flanagan, adoption as well. The next breakout room will be on fertility preservation. Dr. Maya Edie McCarthy is going to talk about her experience with fertility preservation, as well as Dr. Krista Marie Coleman, and Dr. Jennifer Davis going to speak about her experience using a novel treatment involving one of the newer treatments for fertility preservation. So I truncated those. They will introduce themselves in the breakout room. I wanted to get everyone in the breakout room